So our next case, this is the case where Dr. Mikhailov unexpectedly can't be here, and I'm seeing the slides for the first time as you are. This is a 39-year-old male who self-palpated a node in the neck in 2014 that waxed and waned over 4 years. He noted a right groin node in May of 2018. There was an excisional biopsy. In June and July, a right axillary node biopsy. He had a 50-pound weight loss that was, quote, easy. His past medical surgical history is not insignificant, with a DVT after knee surgery and cholecystectomy, depression, discoid lupus, a history of acute renal failure with a creatinine up to 7, an etiology unclear, and type 2 diabetes mellitus. He had bilateral posterior cervical lymphadenopathy of less than 1 centimeter. In his other laboratories, studies are there with the normal LDH. Could we see the radiology, please?
So this is I'm Greg Wiseman from Nuclear Medicine. This is a FDG PET scan done on the 16th of July of 2018. And you see the rotating image, not much going on, a little bit of arthritic changes here in the shoulder. As we look at the transaxial image, still not a lot going on. We got, didn't see anything really in the neck at this time. Down here in the right, some small sort of axillary nodes you can see there, but not real impressive there either. Had a portocaval node. Right in the region right there, and that had SV of 3.5, and then as we heard earlier, there was some right inguinal adenopathy, and there was a node here in the right inguinal area. You can see they're not very big, had a SUV of 2.7, so nothing in the spleen, liver, bone marrow, anything. So kind of small volume, low FDG uptake. Adenopathy.
So the adenopathy isn't very impressive on the PET.
Nope.
That's a fair statement.
Fair statement.
And the maximum SUV of any of those nodes was?
3.5.
Okay. Sorry to re-ask. I was just got lost on the shuffle there for a minute.
No problem.
Okay. Dr. Curtin.
So we have 2 lymph node specimens to review. One from June of this year, which is the right inguinal lymph node, and that's this one here. The thing to notice about this lymph node is that there's a rim of lymphoid tissue around the perimeter and a lot of lymph node hilum with fat. And the same is here. Small amount of lymphoid tissue with a lot of fibroadipose tissue in the center. So it looks like the reason that the lymph nodes are actually enlarged is fat replacement of the hilum. And we'll see that same theme work out in the next lymph node from the axilla. And then as far as the architecture is concerned, the architecture is completely normal in this node. These pink things are the lymph node sinuses and the fibrous trabecula that hold the thing together. These balls are the follicles. They contain germinal center cells with a typical distribution of large centroblasts at one pole of the follicle, maturing to centrocytes at the opposite pole of the follicle, and they're all surrounded by distinct mantle zones. So the cell composition in the germinal centers is really that of a reactive rather than a neoplastic process, and this is consistent across practically all of the follicles. And I'll show you this one here because we'll come back to it in a minute with the immunostains. Again, you can see the centroblasts polarized here, centrocytes here, normal mantle zone cells around it, no crowding of the follicles. So morphologically, I don't think I would have even thought twice about that being a neoplastic process. As you'd expect, the germinal center cells are B lymphocytes. Here's the stain for CD20. And this is the appropriate type of staining that you would see in germinal center B cells, and then the mantle zone lymphocytes. Here's the stain for CD10. It highlights the germinal center B cells. You can see that pretty well here, the balls of CD10 positive germinal center cells. And we'll focus on this follicle here. Again, you can see CD10 positive germinal center cells in the middle of the follicle. There's virtually none of them around the other parts of the node. And then in the center of that follicle, this is the stain for BCL2. You notice that most of the germinal centers have virtually no BCL2 positive cells in them, and that's the appropriate staining pattern. Right? No BCL2 positive cells in the follicles. But then when you get over to here, you can see there's some scattering of very strongly BCL2 positive germinal center cells within this follicle and here.
But in very few follicles.
Almost, yeah, hardly any. Well, very few follicles containing the BCL2 positive germinal center cells, which is an aberrant phenotype, which one generally associates with follicular lymphoma. So here is the axillary lymph node specimen. Again, you can see a rim of lymphoid tissue surrounding mostly fat. So again, the reason that this lymph node is enlarged is not because of the lymph node itself, but because of the fat replacing the hilum. And it has the same basic architecture. You see the follicles. They're widely separated from one another. You see the sinuses, which are normal. He has a tattoo. And again,
It wasn't your ink.
I'm sorry?
It wasn't your ink.
No, it wasn't my ink. It's not my ink. This is not my ink. Here's the stain for CD10. The ink is black. The immunoreactivity is brown. Again, you can see just a few germinal center cells here in the follicles. And once again, most of them, BCL2, completely negative. It's the appropriate staining pattern. But here, a couple of the follicles, 3 of them widely scattered, not enlarged, contain these intrafollicular BCL2 positive germinal center cells. So this condition is now considered to be in situ follicular neoplasia. When it is involving one anatomic site, the chance of progression to systemic lymphoma is very, very small, on the order of 10%. I don't think there's much literature at all about what happens when you see follicular, in situ follicular neoplasia in 2 different anatomic sites. But I can't imagine that this guy has a whole lot of disease burden based on the way the lymph nodes look, because frankly it looks like the nodes are enlarged, not because of the follicular proliferation, but because of the fat in the hilum of the nodes.
I always kind of looked at, this was a very interesting node. I guess when I look at scans, at CT scans, and I see fat in the hilum, my head always moves towards benign, not malignant. I mean, it just, so we don't see a lot of malignant lymphoma nodes with fat in the hilum, do we? I mean, it's more in CT, I guess, than the PET that we could appreciate that. Is that a fair statement? Or?
I think so. I mean, if you want to drill down a bit more, we'll look at the thickness of the cortex. So you may have, you know, a big node with fat, but then if the cortex is really thick, then that's more suspicious.
Okay.
You know, so I'd say cortical thickness is probably another thing to look at.
Yes, especially when seeing these lymphadenopathy cases that no one knows what's going on. When I see fat in the hilum, I really move further away from the lymphoproliferative diagnosis. I just.
So we have encountered lymph nodes that are clearly involved by lymphoma that have fat replacement of the hilum. But I think the issue there is oftentimes sampling. The node that's convenient to remove is the one that's removed, and that happens to be, you know, maybe partially involved. And so I think that's probably what's going on in those situations.
So we really haven't had one of these cases in 5 years. This is interesting. So it affects at least 2 distinct lymph node sites. So any reason to consider treatment with rituximab? Does having the second node make them at higher risk for follicular lymphoma? And what about surveillance? There are 3 patterns seen: follicular lymphoma elsewhere. Some develop follicular lymphoma later, and others remain without evidence of follicular lymphoma long term. Cases I've been involved in, and the first time I was involved in one of these, boy, I didn't know quite what was going on, and the literature was just starting to evolve. And my experience has been more of the third bullet than the other. And so we'll open this one up for discussion and thoughts about management for Ivana.
I personally wouldn't treat with rituximab because his lymphadenopathy is not due to the follicular lymphoma cells. It's due to the fatty replacement, and has a lot of comorbidities, and I'm not sure what the end game would be there.
Well, could you argue, I'll just take the counter argument for 1 second, out of our 2014 paper, we were kind of first to point out that if you got some rituximab, that you were going to decrease your risk of transformation follicular lymphoma.
But that was follicular lymphoma, not this
I
disease
I
entity.
agree.
So
I'm just throwing it out, that's all. Very good. I like the response.
I think we know from PCR studies that have been done on blood that a high fraction of people, especially as they age, come up with 14, 18 translocations in peripheral blood. And that virtually none of those people goes on to develop systemic follicular lymphoma. So I think that this probably is the lymph node counterpart to that phenomenon that's occurring in the blood.
Any comments from anyone else? Gordon. Oops. We somehow lost you.
There is ignoring Gordon.
Gordon, you're ignoring me now.
Is any of this related to his lupus? Is it secondary to immunosuppression from his lupus? Is he getting therapy for that?
It was just he was on discoid lupus. I don't think it was, usually they don't get treated. I don't know. Okay, you're back, Gordon. We'll come back to you in 1 second here. Or come ahead and I'll respond then to another question. Gordon.
Oh yeah, sorry, I turned it off.
We've done each other in once today, so.
Right. So our consensus is to observe. I think maybe patient will need treatment down the road, but if there is no significant symptoms, I think we should observe.
Yeah. So the question came up about the discoid lupus and is the patient on immunosuppression. I don't know any of the details with the renal failure story and everything. This is really funky. My assumption is he wasn't, since Ivana didn't put it on the slides. But I'll go back and ask her, and then we'll find. That's a great question, because that would start to. In looking at the iatrogenic NHL papers, and I've seen a lot of them in the last 5 years, I don't think that's been described. The follicular neoplasia in situ.
I mean, I know the data for using rituximab and lupus, not discoid, but otherwise is poor. But if you needed to use it in two separate things, maybe that would be different.
No, that's really a good point. Yeah, that would be an argument to do it. If he had RA, that would be maybe a different story, since it's pretty active in RA. So the consensus is observation. I think the other thing that over the last 5 years, the beauty of this conference, this case really demonstrates it. And when you get the images up and then you get the pathology up, all of a sudden things start to come together and unfold a little differently. I don't think there's a better way to communicate than just seeing the paucity of the small number of follicles involved in this, and the amount of fat and the amount of it just makes it a whole different. It makes it something different to me.
What would you do for surveillance? I think she wanted to know that too. If you're going to observe, how?
See you back in a year next.
I would follow up in 1 year with blood tests and exam.
Okay.
Does anybody disagree with it?
No.